interventions and therapeutic drainage procedures. Over to Dr. Shah.
So, I am actually a lateral entry into this program, and Amit is a friend of mine, and he called me Monday morning saying that there has been a cancellation, can you please try and accommodate? So, I am a radiologist. It may not be as exciting for all of you sitting here practicing sexual medicine practice, but I'll try to do justice at my end whatsoever best is possible. I would like to thank the organizers and the committee members and my dear friend Amit to give me this opportunity to be here amongst all of you. Okay, so just to what I'm going to be talking about is imaging modalities for pathologies of the penis, and predominantly if you come to see, you might have encountered in your practices, the first line of modality of course is ultrasound, followed by MRI. I'm not sure how many of you might be sending patients for MR assessment, but we'll see to it where it has an added advantage. We'll see the brief anatomy on ultrasound and MRI, and then we'll discuss images on the various pathologies. So my talk is mainly going to have images, and it is much less of written content in it. I've already mentioned why ultrasound is the first time modality. It is much easier, ease of availability is there, ease of expertise is there. It is much cheaper as compared to any other imaging modalities when it comes to radiology. And however, the one issue is that it is operator dependent. So unless and until the operator is well versed or is trained himself or herself in doing ultrasound in the particular desired pathologies, it will be difficult for him or her. Again, MR certainly has an upper hand in particular situations, but the problem with MR is there are very few centers and very few radiologists who would be practicing when it comes to imaging of the genitalia or sexual medicine or even in tumors for the penile abnormalities. So coming to brief anatomy, so this is what you're going to be quite well versed, and I understand because of the practice that you follow. So the two corpora, cavernosa and the spongiosa, the tiny bright specks correspond to the cavernosal arteries, which is there. That's the diagrammatic representation, and this is what is MR that I was talking about. So MR. MR predominantly has some sequences. Let's not fall into the physics part of it, but it is T1 and T2 weighted imaging. And what we are interested in, what I want to depict is, it is so beautifully demonstrates the tunica, the corpora cavernosa and the spongiosa. So that's a T1 weighted image and that's a T2 weighted image. And that's the advantage that MR offers is that I can scan the patient in any desired plane. Okay, so the axis or the abnormality is going to be very well depicted on an MR, because if I'm there sitting on the console scanning the patient, I can scan in whatever oblique plane, even that is possible even on ultrasound. But while ultrasound can give you a focal picture at one particular point of time, MR is going to give you a global picture. It's going to evaluate deeper areas of the pelvis which may not be accessible to ultrasound. So this is, I'm pretty sure all of you are very well versed when it comes to evaluation of erectile dysfunction. So ultrasound has the advantage of providing you with grayscale imaging, with color Doppler imaging and power Doppler imaging, and with spectral imaging as well. So it has a complete diagnostic armamentarium for assessment of erectile dysfunction. And what we are looking at after administration of the intracavernosal injection of the papaverine is that we look at the way the waveform is behaving. Okay, so what happens is that initially there is a low flow because the cavernosal arteries are quite small and we have a very small systolic peak, absolutely no diastolic flow. After administration there is rise in the diameter of the arteries, okay, and there is increase in the influx of the flow which is coming from the cavernosal arteries, and there is dilatation of the sinusoids which ultimately get filled up. What happens after that is that there is venous occlusion because of the sinusoids being dilated, and then there is the outflow, it stops. Because the outflow stops, there is a transient increase in the velocities that we are looking at, followed by there is absence of diastolic flow because there is increase in the pressure in the cavernosal sinusoids, and ultimately even the systolic flow stops because there is a lot of resistance to the forward flow. So this is what we are typically looking at when we are evaluating the arterial influx, while if abnormalities are encountered on the venous side, we can also diagnose venous insufficiency. this of course there can be a visual evaluation of the grading of erection which is happening after administration of the pharmacological agent. So this is what I was mentioning about is, this is the flaccid state of the penis, two bright spots corresponding to the cavernosal arteries. See what is happening. Beautifully the cavernosal, you can actually see it enlarging in diameter, the sinusoids filling with blood. And this is what the report would usually mention, peak systolic velocities and end diastolic velocities. There is an obvious increase in diameter of the cavernosal arteries once you administer the pharmacological agent. So this is just to give you an example of, as I've mentioned, what happens is increase in the cavernosal artery diameter. Initially the flow which was low, it now starts increasing in terms of the systolic as well as the diastolic pattern. With further increase in the flow, the physiology says that because there is dilatation, the veins are supposed to get occluded for the erection to be rigid, and hence initially we see that there is some diastolic flow followed by diastolic reversal, and ultimately there is absent diastolic flow. And what happens is even the systolic velocities, they go down because there is increasing the resistance at the end. So this would be like a normal pattern of a systolic adequacy of the arterial flow. The peak systolic velocity is more than 30 centimeters per second is a good enough factor to mention that the influx of the arterial flow via the cavernosal arteries is good enough. When it comes to this is what I was mentioning about this. When it comes to arterial insufficiency, the diagnosis is made with the peak systolic velocities falling below 25 centimeters per second. And this is what the chart would look like. You would see that the velocities are significantly low on the right as well as the left side. And the patient is never going to attain a good peak systolic peak on the spectral Doppler, and there is continuous forward diastolic flow. Obviously, because there is no rigidity, there is no occlusion of the venous side, and hence the patient is not going to be able to get a good peak systolic velocity. What happens at the other end of the spectrum is when the patient experiences venous leak, is that initially there is good velocity. The patient may be able to, the PSV could go beyond 30 centimeters per second, but because there is no occlusion at the venous end, there is continuity of the forward diastolic flow which you would see on all the phases. We expect this diastolic flow to reverse at some point of time and then stop, but that does not happen. It is basically an indicator of venous leak. The issue is that a patient could have arterial as well as venous dysfunction, but if I am not able to evaluate, if there is arterial insufficiency, I cannot comment whether there is venous insufficiency or not in that situation, obviously, because we are not going towards the other end of the spectrum. So just to mention that this happens, with a normal anatomy, we have right and left cavernosal arteries. In that situation, it is easy for me to comment. But we have a lot of variations. Like there is a single cavernosal artery, either on the right or the left side, and then it is traversing across the septum or to the other side. So in these situations, it could be a bit tricky just to evaluate based on the velocities alone from a single cavernosal artery. So this has to be aware, and as of now there are no strong guidelines to suggest what should be the ideal peak systolic velocity in such situations. There is also a recent paper which mentions that using power Doppler to assess for collaterals in such situations from the dorsal penile arteries is essential. But again, the paper mentions there is a lot of clinical details on multi-center trials to evaluate what degree of PSV and EDV is going to help us to identify such patients, such abnormalities. So this is another example of duplication of the cavernosal artery on one side. This is a single cavernosal artery which is dividing and supplying the other end. This is what I want to show. This should never happen while doing a Doppler. What has happened is that while giving the pharmacological agent, there was some air which was there in the syringe. So you see air specks, it can actually disturb the picture. Air and fat, they are foes of ultrasound, they are friends of CT, but they are foes of ultrasound, so that has to be avoided, needs to be taken care of. Again, this is the paper that I was talking about. These are just to show additional examples of duplication, single artery supplying bilaterally, a plaque, Peyronie's plaque causing interruption of the blood flow distally. You can clearly see that there is good flow proximal to the plaque and overflow distal to the plaque. So coming to my topics of interest is imaging. So what happens in Peyronie's disease is there is plaque formation, there is fibrosis, ultimately calcification may or may not happen, and plaque formation which distorts the shape of the penis and the erection can be painful. So how is calcification seen on ultrasound is bright specks with a lot of posterior shadowing. It does not allow the beam of the ultrasound to be traversed through. Okay, you can see these bright specks which are seen along the tunica which are covering both the cavernosa. What MR shows us in addition to those plaques is presence of active inflammation. You can see contrast enhancement along the side. These are T1 and T2 weighted images. If you see here, the expected signal of the tunica is dark. But if you see on the dorsal aspect, it is not completely dark. There is some intermediate grey signal which is seen there. And similarly, on T1 weighted images, ideally this should have normally been black, but it is not seen as black. It is seen as intermediate grey. And what happens on contrast at these areas, they are enhancing. The normal area they are not enhancing, but the post contrast is showing enhancement along the tunica, which corresponds to the area of active inflammation which is going on in pyroneal. Another example to show, see the length of the plaque which is seen along the pectate septum. Quite a long plaque which is seen there. However, if you see the post contrast, not the entire plaque is showing active inflammation. It is just the posterior segment of the plaque which is showing active inflammation, which is present in these particular patients. Also, you will be able to identify that the clinician is being probably able to identify just one plaque, but the posterior aspect of the penis could also have additional plaques. Just to encompass the spectrum of the pathologies, you can very well identify trauma in such patients where you can see there is lack of continuity of the tunica and associated hematoma, while in other situations the tunica is quite intact, so I'm pretty sure this is not a fracture but just a contusion in terms of edema which is encountered. Neoplasms, you can have a variety of neoplasms right from primary to metastatic disease which is happening in the penis, gross, large neoplasms. You can also identify regional lymphadenopathy, but neoplasms need not always be primary to the penis. They can also be in the perineum arising from the prostate or the rectum and the anal canal with secondary involvement of the posterior penis. So, and just to discuss the last case, this is an unusual penile pathology that we encountered. So, a young gentleman had presented with 1 day history of sudden onset pain in the penis. Okay. Lab evaluation was found to be pre-diabetic and some elevation of WBC count. And the clinical suspicion was either a post-traumatic incident or balanitis. Patient had taken multiple courses of antibiotics but not responding, and then he came for an MR at 2 weeks down the line. And this is what it was showing. It had a large abscess which was occupying almost his entire spongiosa. Okay, so that's the normal cavernosa which is there, the ventral surface showing the spongiosa, and all this bright area, normally even the spongiosa should have this signal, all this bright area was corresponding to the presence of an abscess which is there. He had developed a fistula along with it from the rectum and anal canal, and this fistula had ultimately resulted in abscess into the spongiosa. I hope you had enjoyed, and thank you for giving me this opportunity to be here. Thank you, sir.
Thank you, sir. Very good presentation. The question answer.
एक आधा question please. Sir, significance of the color Doppler in penile color Doppler. What's the significance of the penile color Doppler in ED?
Significance. Yeah. See, it is the most easily available modality for you to assess all these patients. And if you are able to mention that that the peak systolic velocity is beyond 30 centimeters in both the cavernosal arteries, I am confident that there is no issue with the arterial influx which is there. Okay. So all your patients, it is good to distinguish between vascular and other etiologies causing erectile dysfunction. So patient could have a psychological element for this dysfunction, but if you are able to exclude the vascular cause as the cause for erectile dysfunction, you can primarily then refer him to the corresponding.
After giving the papaverine injection, there is some degree of the patient, they have some psychogenic issue and all that, they have some shyness. So the penis is not so erect. So how you assess? Because many seniors are saying there is no significance for that.
See, psychological element cannot be assessed. Okay, my role as a radiologist to let you know is I can confidently tell you if the peak systolic velocity goes beyond 30, I can confidently tell you that there is no arteriogenic abnormality to the ED. Okay, but if it is not, I am not excluding the other factors which are there, including the arteriogenic. So unless and until the patient is taken into confidence by the radiologist and the clinician who sent him, telling him that this is going to be such and such atmosphere and this is what I am going to be doing, the patient is not going to confide in you to do this procedure. So patient has to be psychologically comfortable when he comes to the clinic of the radiologist.
If I'm just prescribing the patient for the color Doppler and you are just giving the papaverine and you are just giving the papaverine after you just creating the flare rhythm, who just is responsible for this issue?
So what I do, okay, I tell the patient to be very frank that this is a possible complication which can happen. I tell him to get, sorry?
You are taking consent about that?
Yeah, we are taking, it is regularly taken. I specifically tell him to get in, my referral based practice predominant from urologists. Okay, So I specifically plan all these patients in the afternoon slot because I don't want the patient to run at 10 o'clock in the evening, trying to find a urologist and then go to the casualty. The CMO is not aware what is to be done. So I do all these Dopplers predominantly in the afternoon, somewhere between 2 and 4 o'clock. So the urologist is going to be available in his OPD. If the urologist is not available for some reason, I talk to him directly and ask him what is to be done. And that is way.
But has there been any incidents of practice?
Two incidents in the past 10 years, sir. But I could, sort it out with the urologist at the same time.
I have one question. Some center are doing this penile after giving Selena 50 million, and some are doing by injection temporarily. So what is the difference in some person?
I am not, I don't have much experience to be very frank with patients who come after taking sildenafil. And I have no experience to comment on that particular thing. So all my patients that would come, so I tell them that we'll be injecting papaverine and do it with papaverine. So I don't have experience with it.
Nowadays, PDE5 inhibitors are available in market. So after 80s, 90s era, now that much importance is still there for the penile doctor?
To be very frank, I don't have a patient primarily coming to me for penile doctor. So I'm a radiologist, so I have a referral-based practice. I do penile doctors only if I'm told I'm supposed to do penile doctor, otherwise I don't do it. So I don't have a good answer to your question, to be very frank.
Sir, what are the indications? We know only the in sexology. We do the sonography for fracture penis and the Doppler or erectile dysfunction. What are the indications for MRI? That's first.
Okay, so MR, when it comes to assessment for Peyronie's plaque, I think pre-surgical evaluation it is quite helpful. As I mentioned, correctly identifying the length of the plaque, the location of the plaque, and also for identifying some other plaques, especially in the posterior penis, which may have been missed on clinical evaluation.
Only primary disease for MRI?
Yes, absolutely. Otherwise, tumors is one strong indication for local staging. Okay. Nodal staging, MR, unless and until the node is frankly necrotic or grossly enlarged, I may not be able to comment whether it is metastatic or not. In that situation, PET CT is much better modality to identify whether it is metastatic. For using MR for staging of local tumors is certainly the modality of choice. Thank you so much.
Thank you for this nice talk.
Thank you, sir. You said that it might be not that much interesting for us, but you really made it interesting.
Thank you so much for giving me this
So
opportunity.
many
Thank you so much.